year, we actually are celebrating in June our 20th anniversary of working in Haiti, and it's been an interesting adventure that I've met more amazing people through working in this country than I ever had leading up to that stage of my life. And Greg is a perfect example of that, how working in Haiti, as in many of the countries you guys work with, you see problems you think are insurmountable. And then through just trying to find creative solutions, an answer will come to you. And Haiti is a place that obviously resources are limited. And one of those limitations is the number of pathologists that are in the country. And our vision has been to create a national cervical cancer prevention program. We had a pathologist that we met working in the country called Rosemary. Her name was Rosemary Edwards, and she introduced me to Greg. Greg's an amazing guy. I don't know if I've ever used this term in front of you, but I think of Greg as being the Indiana Jones of pathology. Greg was in New Orleans at the time of Katrina and set up a little MASH hospital there locally post-storm. And it sort of, in my mind, exemplifies who Greg is. Greg is somebody who likes to get down, get dirty, and be a visionary and find ways of changing the world. And I'm really excited. Number one, for my relationship with him. I'm very grateful for that, but very excited about what he's about to share with you. I don't want to spill the beans on the organization and things. I want to let Greg sort of let that unfold, but he graciously got on a red eye to fly in this morning on his way to another meeting, so we're very blessed to have him here. And Greg, thank you.
Thank you.
Yeah.
Indiana Jones. How about Louisiana? This is a huge honor to me. Being invited to talk to Duke Global Health, I was like, well, yeah, you're right, I'll get on a red eye. This is like my TED Talk moment. So, so I really appreciate the invitation, and I'll try to live up to the build-up. Not only in the story, but I actually kind of got sexy with audio-visual here. I actually taught myself how to do a Prezi presentation, so let's see if that really works. And now, I'm from Louisiana and Mississippi, and we're not known for a whole lot in Mississippi. I can tell you certainly in the days that I grew up, and my sister actually graciously came up to watch this talk. She can tell you some stories too. But one thing we were known for growing up in Mississippi educationally is literature and writing and telling stories. The Faulknerian tradition, that's how we were educated. And I remember my 11th grade English teacher said there are 3 elements to a story. Of course, we go to the beginning, the middle, and the end. No, that was not her point. Her point is that real stories really ask what if, then what, and so what. So every great story says what if, then what, so what. And I decided, since this really is a story, it's a journey, to frame all this in the what ifs, and then what's, and then the so what. So we'll take you through that journey with the let's go. So my what if is the center circle there. So let's see if that works. Nope, that's the last one. Let's see if we can get started here. See? Okay.
Can you look at the first one? That's not far. Yeah.
Jumping all ahead. Well, I gotta do some crazy changing now. So my initial that's what we did is I finished my training. Claudia can attest to that. Claudia and I have known each other a long time, and when I finally finished on my academic training, I went into my first practice in Wilmington, North Carolina, and it was a great private practice situation. We were very successful, and it was one of those situations where me and my partners, it was just sort of like everything we did right, and we had this great life going on and a great practice on the beach. And then about 7 years into it, you looked up, and my first what if is, what if one day you just decide to leave your comfortable life by the sea? At some point you reach a point, it's like, you know what, I don't know what it is, but I need to be doing something more. And so I was recruited by the Ochsner Clinic in New Orleans to come back home to New Orleans and take over the anatomical pathology department, Department of Pathology there, and that was a way to kind of get back into academics and all the things that I initially got into medicine for, teaching, etc. Well, next is, this is what my what if led to, is after a lot of preparation, we arrived in New Orleans about 2 weeks before Katrina hit. So this was my first what if. So what if you make this choice, and then what if the greatest natural disaster in U.S. history hits right at the same time? Now, David alluded to this, and I certainly don't want to talk a lot about that, but in a really, really quite weird set of circumstances, I stayed and rode out the storm, and was in a very sort of twilight zone situation. Ended up being one of very few physicians left in town, and this was a 2-week experience of total chaos and total medical mayhem, and everything that you've all heard. We know the story well. You can advance. This is sort of the picture of the convention center where I did a lot of my work there right after the storm. And I could, and I have, and I could go on. I could give you an hour or 2-hour talk on that experience. But most of the time when I am asked to reflect upon that, there's the obvious question of, well, how did that change you? What lasting effect? Well, it had a lot of them. But from a professional standpoint, what it did was it gave me a direct experience of what I would illustrate with the next picture, this moment, from that movie that we've all seen, that moment in It's a Wonderful Life, where Jimmy Stewart gets to figure out and experience life as if he'd never been there before. He'd never existed. And so Katrina for me was the experience of, what if we don't exist? What happens if all medical infrastructure is gone? And it's not pretty. It really is not pretty. You learn some amazing things in that story. And if that personal experience has effectively driven everything else in my life since that time. Because not only was the immediate loss of all, acute medical care during that situation, but once the storm settled, and a few weeks after, there was the chronic loss. I mean, the people in that slide before, they're not standing in line looking for a pap smear. They're standing there looking to get out and get medication and get food and water. But a month or 6 weeks after the storm, when there was some beginning of organization, then you start realizing, well, there are no pathologists left, because everyone was gone. And so from that time on, I asked, the next kind of what if is, what if we never went away? Now that I've had the experience of, wow, this is what it's like going away, what if there was a way in which, focusing now on pathology, that we were really never absent? And in the first year or so after the storm, it was really just kind of a reflective bee in my bonnet, if you will. And about a year after the storm, I went to our national CAP meeting. And right about that time, some new technology was emerging that led me to begin to think about, well, how there are ways in which we could actually always be there. Next slide, please. So let me frame what being there means in terms of a pathologist. And the way I know I'm speaking to a very savvy audience about what pathologists do. But very often, one of the banes of our existence is people don't know what we do for a living. They think we are solving mysteries and things like that. And I can assure you, I've never solved a mystery in my life. I can barely find my car keys. But what we do is we are physicians who take care of patients. We take care of patients with information. The medical doctors, or internal medicine physicians take care of patients with pills and medications and stethoscopes. Surgeons take care of patients by cutting them open and sewing them back up again. We take care of patients with information. And so the guiding philosophy of my professional life is, if the way in which we treat patients is about delivering information, that in the same way that surgeons are constantly looking for innovations in technique, in surgical technique, and internal medicine doctors are constantly looking at drug development, we need to be always looking at how do we deliver more information, better information. That's the refinement. So what does, next please, what is good information? Well, good information is got to be accurate, it's got to be rapid, it's got to be meaningful. You got to know it's got to translate into something. It's got to be savable. It's got to be useful to somebody. But most important, it's got to be available. And the experience of Katrina was it not being available among so much else. That is, my ability to take care of patients I'm hamstrung. I cannot deliver that information. So as I started thinking about, well, if this is what business we're in, how do I always make my information available? Well, the short answer of that is what I embarked upon at that time is, I'll give you a quick lesson, hopefully not too in-depth, about the way in which pathologists deliver information. Claudia and I remember the days when, we actually remember the days when information was delivered by typing up reports at Vanderbilt Hospital and signing them physically and walking around and putting them on a chart. Now, we've actually lived through the era where now that's done with electronically, which we would call anatomic pathology information systems. And the standard of that is, pathology practices, either small private practices or large enterprise level Duke University practices, have a computer system, which is basically a database that is, you enter the diagnosis and you render a surgical pathology report, and that pathology report gets distributed either electronically or printed out. But really the norm still is most pathology practices running a server in their office that is able to run this database. And whereas it's effective in generating a report to communicate with doctors sort of locally, it's very limiting. I mean, your computer system is in your office, and if you want to log into it, it's very complicated, et cetera. So I had the idea, if we really wanted to make an innovation, a real innovation in information, is let's at least be able to access patients' reports and sign out reports and make pathology reports in such a way that's as easy as like doing online banking, which means that let's put it all in the cloud. Now, I'm kind of glad that I'm able to have this conversation now and use terms like cloud. We were having this talk 2 years ago. I think the word cloud computing was still kind of a mystery to everybody. But now with iCloud, I think we all kind of know what the cloud is. It's this mysterious place. That's where my banking data goes. That's when I back up my iTunes, my songs live in the cloud. We all know that. Well, why can't we practice at least pathology in the cloud? So about 5 years ago, the sort of first step on this journey was I began a collaboration with a company in Southern California called Path Central to develop what is effectively the very first cloud-based anatomic pathology information system. I wanted to be able to open my laptop anywhere I was in the world and either sign out a case, generate a report, log in, just like you would do on your bank. And that actually proved to be a heavy lifting sort of project. The first part of this story I'm telling you that whole adventure took about 3.5 years to actually get something that was usable. And it's actually proved to be somewhat successful now, not just with this sort of little pet project that I've got, but that company now powers anatomic pathology practices all over the country, about 30 of them. They've made the choice to say, you know what, I'm not going to spend $500,000 to put hardware in my office. I'm going to sign up for a subscription, and I'm going to log on, and somebody else is going to be hosted in the cloud. And guess what? We can start doing anything we want to do anywhere. Well, next. My next what if is, what if an even worse natural disaster occurs? Which, of course, is the next picture, this. Now we dial forward to 2010, January. And around 2010, we had successfully implemented this sort of cloud-based system in my practice, and we were able to use it to start basically freeing ourselves from the chains of having to sit in my office and do my work every day. And then this horrible disaster happens, the Haitian earthquake. Next slide, which pictorially is as horrible as the other picture, and as pathetic and as moving, and I think we all have a direct experience with just how bad that was. But what the next what if is, what if a guy named David Walmer calls you? Do you take the call or not? You let it go to voicemail. Because as David described, I mean, I didn't know this guy through Rosemary. You know, we got connected, and David calls me up, I put about a month after the earthquake. I say, okay, here's the deal. I was going to build my own pathology laboratory, and I've got about, and what did the building fall down and covered all the equipment that y'all had just had shipped over there, so it was all buried. And I've got about 200 cervical biopsies in formalin. Can you help me out? And I said, okay, yeah, send them. Can you get them here? So put them in a box and send them to our laboratory. And he said, I don't know how you're going to get the reports to me. Maybe you can mail them to me. I was like, no, I can get the reports to you because I use a cloud-based anatomic pathology information system. I can not only generate a PDF, but when you're in Haiti or wherever you are, you can log on and see them whenever you want to. Cool, right? So that was cool. And so David started sending me cervical biopsies. And so for about the first year we worked together, you sent biopsies and I sent reports, and y'all were real happy. And then we started thinking, how can we make the next step of this? We've got the raw materials here to, as David said, solve an amazing public health problem. I mean, global public health problem, which is, in my opinion, probably the least known global public health problem out there. We all know about struggles with malaria, all the high-profile things, but the public health problem, or the global health problem I'm referring to, is the lack of access to a diagnosis. As I started looking at this problem, as David started, telling me, right after the earthquake, he said there was 10 pathologists, then they went down to like 4, and now they've built up again. And what is there, 8 million people in Haiti? You start going around the world and you say, well, okay, how many pathologists are there outside of the medically developed world? And you start discovering that, not just in devastated nations like Haiti, but as you go to India, China, the BRIC nations, Russia, the Middle East, the per capita ratio of pathologists is on the order of a 1 to 100 or 1 to 1,000 what we have here. So in the United States, it's easy to get a diagnosis, relatively. There's pathologists everywhere. But in the rest of the world, just getting a diagnosis is a real difficulty. So we thought, okay, well, this is, if we can solve the problem in Haiti, maybe we can figure out a way to scale this all over. So that's what happened when David Walmer calls. Because what we really thought is, one of my favorite things to talk about when I talk about my home, New Orleans, is I refer to New Orleans as the city where joy was invented. And I think we all know what we mean by that in New Orleans. I should have a Mardi Gras picture here. But conversely, Haiti is also a place of great joy, but it's a place where hard was invented, where difficulty in life was invented. These are the pictures I shot when David took me to Haiti last year. And this is about as emblematic of him in Haiti as any picture I've ever shot. Advance a few more of them. This is Haiti. This is my personal experience of it, and I think it just captures the spirit of what the country is like. It's a wonderful group of people, but they're struggling in a way that I thought I saw struggle in New Orleans, and now I saw Haiti. Next. But it's got its own beauty that's almost indescribable. I just thought the pictures tell words on it. So if I want to start rendering diagnoses in Haiti, so I start thinking, okay, David can continue to send me cervical biopsies and we can do it this way, but right now, really the fundamental tool of pathology since the late 19th century has been this thing, the microscope. And remarkably, for all the technological advances in medicine and all of the finer testing that we can do in pathology, DNA testing, special stains and all that, as amazing as it sounds, this technology of the microscope has largely remained unchanged until recently. This is the tool of our trade. So how can I possibly do diagnosis when this is what I need in order to do that? I've got to physically go to Haiti, set up a microscope, etc. Well, no, not anymore. And that's the second part of the story. What if I didn't need a microscope? Well, right around about a year after Katrina, I went to the CAP meeting, and there was a new technology that was really beginning to be shown on the vendor floor, and that is this technology of whole slide imaging. So what is that? It's this. This is the one we use. These are to frame it. Remember 12 years ago, most of us in the room are have been around long enough to know that in 12 years ago, your image of a radiologist was a bunch of guys and ladies sitting in the dark rooms of the hospital doing like that with film, pieces of film. Well, radiology underwent a digital revolution. All those pieces of film were done just like your digital camera. That film went away, and it all went digital. And it totally changed, and if you will, disrupted in a positive way the entire field of radiology. Because now that you're not having to look at an image on film, you've got a digital image, where we all know digital images can be. They can be transported anywhere, they can be stored in a way that cannot be lost, etc. So radiology underwent a transformation because when it went digital. Well, pathology, this machine and other vendors who have made these machines came out with technology that allowed me to now take that little glass slide that I've been spending 20 years of my career looking at under the microscope and put it into this thing and scan it and turn it into a digital image. And that digital image can be done the same thing with the radiology images. It can be transported, it can be stored, etc. Next slide. But why are we so much slower than the radiologists? Okay, so radiologists did this 12 years ago, and really within 2 years, it was totally converted. We couldn't find filming after 2 or 3 years of it. Pathology, now I'm telling you, I saw this stuff on the vendor floors in 2006, and now it's 2013, and I'm about to show you that we're the first people really doing it like it's to be done. Well, there's some real fundamental issues about it, and I don't want to sound like a techno geek, because I'm really not. I've kind of had to learn about this, but it's pretty fascinating. And one of the fundamentals is that little glass slide has about 100 times more data information than the average grayscale radiology image. So there's a lot more data on that slide, number one. A lot of people don't realize is that whereas a radiology image is just a 2-dimensional grayscale, a pathology image is actually 3 dimensions. It's just the 3rd dimension is very thin. And as Claudia and I both know, and Diana and I both know, we get a lot of information by storing a slide, and we see pathologists focusing up and back and forth in that tissue. So that's a huge amount of data. So the technology to scan these slides started 6 years ago, but then it was like 6 or 7 years ago, and it was like, oh my God, we've got these massive files. How are we going to store these things or transport them? Or we're going to live sitting here on a server? Or, it's okay, we can digit it, but what can we do with them? And the reality of it is, until now, and again, I'm going to toot our horn a little bit because we've figured out some solutions to this problem. Probably right now, we're still in that phase of digital pathology. That's probably the biggest issue right now in digital pathology. Again, one of my favorite ways to explain this in an everyman's type of terminology is digital pathology is about where digital photography was in about year 2000. Remember when we all put away our film cameras and said, oh, let's go buy a digital camera. And first you decided on your vendor. I'm a Canon person, or I'm a Nikon person, I'm a Fuji person. So you ran out in year 2000 and you spent an enormous amount of money for your first digital camera that didn't have even as much stuff as my iPhone has. So you bought that and you came home and you opened up the box and you took out your camera, and then you also took out about this thick worth of software. Can't remember that? And then you had to sort of take all the software and load it on your computer, and then you shot your pictures. And then you came, and the only way you could look at your pictures was if you had all that software loaded onto your computer, and you said, okay, look at my pictures, and I can adjust the red eye, and then now what do I do now? Well, I got to make remember you had to make a disc and go down to the drugstore and get them to print it out for you? That's not unlike where digital pathology is right now. You go and spend $250,000 for that Leica machine that I said, and they come and they wheel it in your office. It's a great digital camera, and they got this software package that you pay even more for, that you download the images, and then it sits on your computer, and you go, what do I do with them on my desktop? How do I make use of that? And that's been the challenge. And what the transformative event for digital photography is iPhoto and Flickr and all those sharing technologies, when now you go and spend a lot more for the digital camera, or else you just use your iPhone, and you go by and you open the box and there's this much software that they still sell you, but you throw it in the trash because all you're doing now is you shoot pictures, you jack it in, and you download the iPhoto, and then you start shipping it everywhere. So that's what we realized, that's what we needed to do. To take a bunch of, in fact, that's what the field is, to take a bunch of digital images and have them sit on a computer next to your desk and be really unable to share in an effective way is largely useless. So that's been a huge barrier to entry in the field. Next, please. What's the solution? The cloud, again. So, and the reason why this became really, really apparent to me, and again, I've got to emphasize enough that this is all the stuff I've had to learn solving the fundamental problem of how do I provide service to David in Haiti. Because last February, when Jan and David and I were down there, okay, here was my plan. We were going to put in a pathology laboratory, which we're still going to do. And we're going to cut the slides, and we're going to go with these scanners, and we're going to put it right next to it, and we're going to scan those slides, and we're going to send them to pathologists all over the world who want to participate in this project. And then I actually started, like I said, looking at these scanners. I said, well, wait, hold on. That thing's going to be on a server in Haiti, and I'm going to get those images out of Haiti to somewhere else? It's like, well, number one, I don't want to run a server in Haiti. And number two is, how am I going to reliably get into that server through some sort of complicated VPN stuff that I basically don't understand at all? I was like, oh my God, I've got a real problem. This isn't going to work. I mean, I was calling, he's like, I don't know how we're going to solve this problem. And then I said, well, why don't we solve the problem in the same way that we did with the information system part? Is there a way that we can take those images and still scan them in Haiti, but use the internet connection that we've got an internet connection, and push them into the cloud? When they live in the cloud on servers elsewhere, you can easily get them. Well, long story short, that's exactly what we did. We basically rolled up our sleeves about 7 or 8 months ago and found, you know, the right people who kind of knew had versions of these viewers in the cloud, and sewed it all together and essentially solved the problem. And if I were really cool, I could click on that and show you where you're going to go, but let's wait to the very end and I'll show you with this. But bottom line is, by clicking that URL, as I'm going to show you here, you're going to be taken immediately to a slide that can be driven in any format, anywhere you want to go. What we've been able to do is develop a technology and a cloud-based storage system for slides, where it is literally as easy as sending somebody a URL that you can send them on an iPhone, an iPad, email, anything. You can click in and look at the slides, and it's just a huge leveraging of cloud technology. And my punchline at the very end is, I'm just going to sign out a case for you, a Haiti case, and show you how this works. So I'll skip over that piece of it and say, well, so what? Well, the so what is, now we can actually, and I have, I've been refining this system now for, it's been about a year now since we figured out this. Well, the cloud solution started really in June of last year, and so for 6-8 months now, I have signed out almost 400 Haiti biopsies using my laptop computer. So now sewing these two technologies together, being able to look at the slide through this cloud solution and be able to generate a report. I've been practicing pathology and taking care of patients with my laptop computer anywhere I've got an internet connection. I've done it at 30,000 feet when I'm flying, you know, and I got a go-go connection. It was cool. I was in Dubai about 3 weeks ago talking about this, and I sat in a lobby of a hotel room in Dubai with a Wi-Fi connection and signed out patients from Haiti, and I was like, this is amazing. This is really where we are. Is that with a laptop computer, we really can get to the point where we can now practice pathology anywhere. And it's only been by addressing this fundamental problem in Haiti that we've been able to refine this system. So, so what really is ultimately this. These are the kids that I kind of bonded with when I saw last year. And what the miraculous thing about this is not that these are just the coolest kids I ever met, but one of the most exciting things, and I made the analogy with David when we were at breakfast this morning and a couple of times recently, is I guess the way I feel about what we've been able to do with this system is, I said, okay, well, I need to get from Seattle to Portland, so I'm going to build myself a car. And I've got a car that now will get me from Seattle to Portland, but what we're realizing now is, wow, that car can drive to Los Angeles, or that car can drive to Montana. Is we've got this technology now, and the more we think of ways to use it, it's starting to blow our minds. And one of the most exciting ways we're starting to use it right now is also in education. So when I look at this generation of kids, I say, well, these are 5- and 6-year-old kids. Imagine a day, 15 years from now, where if these kids want to become doctors, we could, or pathologists, God forbid, we could actually train them using this infrastructure. We're actually starting a project right now with a Turkish pathologist who's at UCSF, who's doing the first complete online e-textbook of neuropathology, pediatric brain tumors. So, because even getting a textbook of neuropathology is very difficult in a relatively developed area like Turkey. So we said, oh, well, it's cool. We'll combine the e-book, and rather than those pictures that they put in the textbooks, so you kind of go, well, that's a crappy picture. We're just going to put the slides, live slides. So somebody's reading, here's your textbook, here's these 5 cases of neuropathology. This is the real live slide. You can teach. You can annotate these things. You can say, look here. I feel like John Madden. Hey, look at this cell. So it's been pretty cool, and I'll show you that. So this is why we're doing this. These kids the opportunity that this will open for not only patient care, but for education, is just something that excites me beyond words. And I've got to thank, before I show you how I actually do this, of course, I've got to thank my team. And my team is my employees back in my practice in Seattle, who, and I'm trying to decide, most, these are histotechs and our lab staff, all of whom got so involved in this project and have basically done this in their spare time, to say this is the coolest thing we've ever done, Doc, and every single one of them has figured out and added to value to this, including my daughter, Margot, who's 17 years old. And the coolness of this is Margot can sit with her laptop computer in her bed and get onto these slides and be my database manager. She can just say, okay, we can tee these cases up and organize them because it's in the cloud. So it's been pretty cool. And of course, the relationship of all his family health ministries, that we've been able to form this relationship and solve this problem. And again, as the title of my talk is this one little town in Haiti is absolutely changing diagnostic medicine. Everything that we've learned here in the next 2 years, I'm convinced, will totally change the game. So let me then wrap up with showing you how I sign out cases. At the end of the day, I think this is more of a show rather than a tell. So I'm going to plop myself down here. Is this showing on the webcast there so that people can see that?
Okay. Anything that's showing on the screen.
Cool. So this is our website. We formed a company around this about 6 or 8 months ago, and we figured out we had some solutions here, and we called the company Pathforce DX. And so everything I'm showing you here is stuff that lives within Pathforce DX, and Pathforce DX is now formalizing its relationship with David in a way that is going to be really exciting and actually do a lot of cool things. We're going to be talking about that this afternoon. But so the 2 real functional parts of Pathforce DX are this part. This is that anatomic pathology information system. Okay, so this is, now I will tell you that these are all for patient safety and patient identity stuff. These are all real patients, but I've changed the names, obviously. Coco Chanel is not. That's a terrible sister. So this is how our system works. I mean, basically, I log in. It's driven, just as I said, my vision of it is why can't it be just like my online banking statement? So I log in, and this is my list of patients I've got to do today. If I showed you the long list of the real list of patients that I've got about 500 and what is it now, Missy? How far behind am I?
You're far behind.
So of course the final punchline is is to make it appeal to Claudia and other people and Diana to join what I call the force of pathologists who are actually participating in this project. So these are 5 patients that I've just changed the name on, and this is basically my list of to-do. Okay. So the other piece of it is this piece of it. These are the slides. So I've just logged in beforehand. And so let's do a patient. Let's do Tempest. So let's click on our slide. I got to re-log in. Hold on. Maybe it's going to time out on me. Okay, there she is. So we click on Tempest. Now this is all running, this is real time in the cloud. This isn't like the sales rep demo. This is what I do all the time. And so as fast as it runs today is how it runs. So this we've designed this so it basically runs like a Google map. I affectionately call myself the village idiot. I'm the founder of this company, but also the village idiot of the company. And that's actually an intentional idiocy, because what I've realized is that unless this is literally as easy as a Google map, people are not going to use it. So we try to make it very easy, and it is. This is this patient's slide. We have a navigation tool here that works just like the Google map right here. And since we have some pathologists, we'll easy to say that this is an obvious cervical biopsy. And this is the real image quality. No smoking mirrors. So Claudia, what do you think? What's your diagnosis? I get to do this to you now. Now as a resident, you used to do this to me. So I'll give you a hint. I'll give you a hint that all these patients are HPV positive. So it does help you.
I'm a pathologist. You got to jumble them up. It's right wrong.
What do you think? A low-grade lesion?
Yeah.
We can bop around to different sections here. We got a little navigation map here. We can bop over there and jump to that slide. Look at different sections. So without torturing you all with a lot of pathology type stuff, I'll pretty much agree that I would kind of keep that as an HPV, type of low grade. I don't even know if it's CIM1 lesion yet. Let's take a look at one more section to see if we're good on that.
So these are all cross sections of one sample, or how does that work?
Yeah,
like if you layer them, that would be the
right. This is what we would look like if you look around the glass. Basically, this is a biopsy of a lady's cervix, which is a small piece of tissue that is processed, and a slide is made. And so that piece of tissue, probably when they took it, was 5 or 6 millimeters thick. And it's processed, and multiple sections are made through it. So all of these sections are step sections through, and we do usually, we try to cover as much of the slide as we can to get what we believe is a full representation of the sample. But sometimes if we were looking at the specimen, we say, you know what, there's something else going on here. We can take the paraffin block, which is where the tissue is, and cut what we call deepers, and we cut looking as much as we want to. But in this particular case, I think, just the sort of experienced eye tells you that with about, look like 8 sections there, it looks like we've got a pretty good representation of what's going on with her. There's not really a need to get, any deeper in it. So I am prepared, with Claudia's help now, to make this diagnosis. So now we can go back over, and we said that was Miss Tempest. We click her. And this is our way we report. This runs a little bit slower. And we've organized this in such a way that, the goal is we want to go to one screen and have everything a pathologist would want to know right in front of them. So we kind of organize it in this sort of tabbed browser. Here's our patient summary, patient detail, these patients, again, now number one, these patients are assumed names, and the patients from Haiti, we don't get a whole lot of information. But in our real life practice, we'll have insurance information and billing information. Everything you want to know is in these various tabs. Well, we can code it and bill it. We've got a nice feature here that you can, tag it just like your tag something on Facebook. You can sort of make up your own tags and say, oh, I have cool cases or this, and click them. So it's always storable. If I'm leaving town on a red eye and I want to send it to somebody else, I could actually, click down here and send it to. Well, actually, this is to. Let's say I wanted a second opinion from Claudia. I could click on this and it shows up in her work list, and she could take a look at it and send me back what her thoughts are. Or if, like I was about to say, if I wanted to bail out and get on a plane, I could actually send that case to her and say, guess what? It's your case now. So that's all the kind of nuances of this system. But the meat of it is right here. It's like, how do we make a diagnosis? We go into this section here, professional diagnosis. And I have actually, we basically canned all these diagnoses. So we've agreed that this is an HPV. So, most of these, this is standard terminology on this. Okay? And so that is what this patient's diagnosis is. I actually always put a comment in here too that says this is how we actually made this diagnosis. We did a digital review comment. So I looked at it with a slide scanner. And scroll back up here. This is a preview of my report. Looks good, no errors. Look at it here. As soon as this thing shows up in the final PDF report, in fact it's signed out right now, that case is now signed out. As he gets a copy, you get a copy, case is done, next case. There it is. So that's just a copy of the final report. So that now shows up, you're getting a Haiti, et cetera, it's an electronic version. And that's how I've been practicing pathology for a year and a half now. And it's just, there's some refinements that we want to make on it, but that's really all you need to do. You have a laptop, you look at the slides, you render a diagnosis, and we move forward. So it's been a huge innovation. If it seems easy, it is, and that was the point, is to make it easy. Now, the cool part about this is there's been all manner of things that we've been able to, do sexy stuff like this. Like, watch this trick.
So Greg, compared this to your prior practice where you had the glass slide, and one of the caveats for teaching was like it's so slow. At least, I mean, this seemed really fast, but the older system is very slow. Much faster driving, moving that slide yourself, next case, next slide, as opposed to waiting for this to, pixelate and look good on the screen for you. How much longer do you think it takes you now for the case?
I can, when I'm rocking and rolling with glass, in fact, I was signing out last night around 6 o'clock before I got on the plane. I probably did 20 cases in about an hour, when you're really rocking. Cervical biopsies that are not too complicated. I can get up, my routine is when I'm getting in the groove with this, I usually get up and have a cup of coffee and I'll knock out 4 or 5 cases in the morning. It'll take me about a half hour. So it's slower, there's no doubt. But there are some interfaces that we're working on that might seem immediately intuitive to you, because right now, I'm driving this with a mouse. We're working on a system where you drive with a tablet computer, with a big team. You can drive just like the slide with your hands. It actually works on the iPhone like that. And so what we're doing, and actually the trick I'm going to show you here, is this is all secure data too. This is ultra secure. There's no issues with HIPAA, problems, etc. But I can, with that one field right there, I can do this thing called sharing a link. And I can just basically edit, copy that link, and that becomes an embedded URL. So let me show you how that works. If I actually put now and drop that URL into a browser, it takes me right to the slide. So that's I can generate a unique URL for every single slide. So where has that been useful? We found this, and again, this is one of those things about how many ways can we use this tool, not just to provide service to David, but dear Dr. Smith, this is a really cool case in an email. Click the link below, and you can look at the slide. I think we're looking at the actual slide. I can actually also annotate this stuff. So let me give you some, go back to a case here. So let's open up hers again. And I can do this. Let's go a little closer here. So actually go up in here, if I get the window there, and say, that just saves. That's a way that we're communicating with physicians. I can just annotate it and point at this, say this is interesting, this is your positive margin. I can create, now if I make a link to that, the doc goes directly to the slide and says, okay, this is the slide, look at this. So, and all that stays, basically secured within the cloud. So we're using it as a tool to communicate with other physicians. And the latest innovation that I'm pioneering in Seattle actually is to communicate directly with patients on this. That's been really exciting. Is we're focusing specifically on breast cancer patients certain patients, and again, we're piloting this at a very early level now, but the idea that a patient now we can, in this system, because it's all in the cloud, we can generate for the patient her own username and password, log on, here are your slides, here's an annotated, this is your cancer, this is the benign stuff, and then this is the benign areas. You can actually teach patients about their pathology. But the other interesting thing about it is if you get patients would imagine, a patient who has multiple biopsies, or imagine a physician who wants to, a non-pathologist physician who wants to maintain files on their patients, would log in and have basically their files as slides on all the cases that they want. But with this button here, and this is what we think is one of the most exciting aspects of this, is we've got our famous share button. So imagine that the breast cancer patient gets this as her own secure site where her breast cancer biopsy can live, and she can hit the share button, and she could either generate a link, or if we enable her, that share button will say, please invite Dr. So-and-so. So a second opinion could be sought with this. I would like to seek a second opinion on pathology without even sending slides somewhere. So the ability for the patient to be educated and empowered and seek second opinions, et cetera, through a digital environment has been really, really exciting. The other thing we can do with that long URL, that we're doing with all David's reports, is that URL is actually embedded in the PDF report. So if you pull it up, the report in the PDF viewer, Adobe, and you click on the URL in the report, it takes you to the slide. So now David and all of his colleagues in Haiti have access to the slides. So I've got slides, they can look at the slides. The data collection and mining on this for the research projects that we're going to start talking about is just phenomenal. And but the real thing, Diana, was, and you're hitting the nail on the head. We did this project before we figured out the cloud solution, starting in I guess it would have been early last year. We were doing this project by literally logging into a server through a VPN connection, and you're right, it was pixelated. To get through one case, it was like, oh God, this is never going to work. But now that we've gone into the cloud with this, it's as fast as this. I mean, it's just driving around, and again, with an iPhone or with some of the pad computers we work on now, you can drive with your hands. It's much quicker. It's as quick as you want it. So that's where we are. That's how we've taken care of the patients in Haiti, and that's how we think we're going to change diagnostic medicine, not only in the United States but globally. So I got 10 minutes for questions. That's